Love you.
Don't be scared. It's going to be fine.
In the UK, some 3 million major operations are carried out every year.
I'll be there with you all the time, okay? We'll look after you.
But some patients' procedures are so complex, only the best surgeons can perform them.
Everybody happy?
Okie-dokie.
As soon as the patient is on the operating table, their life is in your hands.
Addenbrooke's and Royal Papworth Hospitals in Cambridge are world-renowned for their pioneering techniques to treat conditions that few others dare to take on.
It's a bonkers job, kind of like something from science fiction.
But pushing the boundaries of modern medicine comes with great risk.
I've got to get this right.
Things can go wrong very, very quickly.
We've got a venous bleed.
You need to be able to accelerate from 10 to 100.
Don't pull, don't pull. Jesus, what's happening?
The surgeons bear the ultimate responsibility.
We have a problem. There's a big problem. Can you just stop talking?
When things don't go as well as they should, then you start to question, was it something you did?
I have operated with tears rolling down my cheeks.
Doing our job takes its toll, but being a surgeon shows you life is precious.
That's it.
Youth.
Come on.
Bravo. Woo! Happy days.
This is somebody's life, and it has to be done perfectly every single time.
Royal Papworth is the UK's leading heart and lung hospital.
OK, can I have the drill, please, and suction?
Specialising in the most complex cardiothoracic surgery performed in the country.
So 2 pairs of forceps, please.
It attracts world-leading surgeons who cure life-threatening conditions by repairing and rebuilding hearts and lungs.
All right, check this valve out.
Consultant Arman Kuna has carried out more than 5,000 operations in his 25-year-long surgical career.
I come from a medical family. My grandfather was a doctor, my father was a surgeon, and my wife's a doctor. And we've got a daughter who's going to medical school in September. When I was a younger child, when I'd gone back to India, my dad's elder brother and my grandfather set up a hospital in our family village. And I would help out in the hospital in my school holidays. And I think that that really made a lasting impact on me.
Today, Armon is preparing for a particularly challenging case, which will test the skills he's spent his life perfecting.
So we need to leave 10 a.m.
His patient is 30-year-old Danny, who lives with her partner, Delia.
We met online. I saw a strong, independent woman, someone who's raising 4 children on her own and doing an incredible job. And then a year to the day we met, we got married. And that was 8 years ago now.
In March 2020, Danny experienced trouble breathing and developed a persistent cough that continued to worsen every day.
It's quite high considering you're sat down.
Yeah.
She ended up in hospital with pleurisy and a double chest infection. It was like a car crash, to be honest. 1 minute it's one way and the next minute your whole lives are turned upside down. To have someone so resilient struggle to breathe in front of you is... it's not easy to see.
It was assumed to be COVID, but 6 months after developing symptoms, Danny was sent for a chest X-ray.
The following day, I was told they'd found a tumour and it was cancer. It was a massive shock.
The tumour is in Danny's airway and led to infection which has damaged the top part of her lung. She's come to Royal Papworth for extensive surgery to remove both the cancer and the damaged section of lung.
So Danny's got this rare type of tumour, a cancer, and it's grown so that it's blocking the airway on the right side. And what that means is that air can't get in and out. If this isn't treated, it can make her very, very sick and it can kill her.
Danny's tumour is in her right bronchus, which delivers air into the lung. It's blocked off her right upper lobe, causing infection. Arman wants to perform a sleeve resection. First, he must remove the section of bronchus containing the tumour, along with the damaged upper lobe. Then he will need to carefully reattach the lung to the airway. If a connection cannot be made, the lung won't work, so Arman will have to perform a pneumonectomy, the removal of the entire lung.
Thank you.
The worst thing that could happen in this operation is that we could have torrential bleeding and Danny could die. The second worst thing that could happen in this operation is that I'm not able to join the remaining lung back to her windpipe, and she'll lose the lung. The stakes are very high.
The blood pressure is elevated, but I've mentioned that to the doctor.
COVID means Danny must face the wait for surgery alone.
Hey baby, how are you feeling?
Nervous now, it's getting quite close, isn't it?
I love you.
I love you too, Lou.
I know this is scary and I'm so sorry I can't be to kiss you, and however the outcome today, know that I am in your heart, you in mine. This is the next best thing.
Definitely needed those tissues.
By midday, operations are underway in all of Royal Papworth's theatres. Danny's is taking place in Theatre 4.
I'm trying to stay positive. So, worst case, I lose a lung, but I'm hoping that's not going to happen.
Welcome to theatres.
Because Arman is working on the airway, he needs extra protection against airborne disease.
Thanks very much for being available today.
I'm really honoured.
Assisting Arman in theatre today is senior surgical care practitioner Trudy Bircham.
Several hundred operations later, several thousand operations later.
Yeah, and we've been through some real old tough things, haven't we?
Originally a nurse, Trudy retrained to become a type of surgeon who assists the consultant in theatre, acting as Arman's right-hand woman.
I never expected to be where I am and be doing what I am. I had a little dream, but I never thought that dream would come true.
Trudy is absolutely brilliant. When I'm doing a complex operation, I would rather have Trudy with me than almost anybody else.
I've been working with Armon for almost 20 years now. We're like a work husband, work wife type thing. I often don't need him to ask me to do something because I've already done it, which makes his life a lot easier.
Did you see the kids and your wife this one? You did? Yeah, good. Everyone's all right?
Some of the procedures that we do demand an awful lot of you. And if you don't believe in yourself and what you're capable of, you won't succeed.
Can I have the light handle? Thanks.
Arman's ready to make his first incision.
All good, Simley?
In Danny's side, under her armpit. Over the next 5 hours, he must not only remove a dangerous tumour, but also successfully rejoin Danny's airway, or risk losing her lung.
A case like this will always be challenging. We've got to be ready for bleeding. We've got to be able to react. We've got to be completely prepared for the unexpected.
Next door at Addenbrooke's Hospital, plastic surgeons Richard Price and Animesh Patel are also preparing to take on a complex tumour in reconstruction.
Should we go in this way? Yes. Yeah.
The procedure is so extensive and challenging, it will need the expertise of them both.
I much prefer bigger operations to be as a double act, as with colleagues. I think it offsets some of the pressure.
We have a very similar approach, especially to the complex operations. Richard is very methodical, likes to have everything planned, and he's very meticulous.
We play it through, we talk to each other, so we both know going into the operation what's going to happen.
They have a combined experience of 21 years as consultant plastic surgeons.
The first thing that comes into people's minds is cosmetic surgery, and I think that's a very common misconception with plastic surgery. The majority of my practice is dealing with cancer patients.
It's all over the muscle, and it's all over that bone.
Today, their patient is a 68-year-old man who has basal cell carcinoma, the most common skin cancer, with over 100,000 cases diagnosed in the UK every year.
It is very close to the orbit.
It is.
But in this patient, it's growing unusually deep into his face, around his eyelid, and dangerously near to his eye.
And I do think we should take the bone out to be sure.
It needs to be removed urgently, but the operation risks leaving him blind and will create a hole the size of a credit card in his face.
Operating on the face is always challenging. It is obviously the first thing that you see when you meet somebody.
How long to go now?
No.
Their patient is former fighter pilot and commercial airline captain Paul, accompanied by his wife Frances.
Yes, it'll look different, won't it?
Might be an improvement.
No, it can't be an improvement, for sure.
You never know.
Paul was first diagnosed with skin cancer 15 years ago. Despite 2 procedures, it's returned again and is now growing around his eye.
And let's hope it works this time, huh?
Yeah.
We don't want to be doing this again, for sure.
Hopefully not.
Paul's condition is rare because in 98% of cases, basal cell carcinoma is slow to grow and easy to remove.
I don't really have the option of not having the operation because although it wouldn't happen immediately, things are not going to get better if I don't go ahead with this.
If left untreated, the cancer will continue to grow, burrowing deeper into the eye socket, causing blindness, and could start to invade Paul's brain.
Hello, good morning, it's Paul.
He doesn't shout about it because he knows that's not going to change it right now until he has the treatment, and then hopefully that does get it sorted once and for all.
You're very hopeful that this will be they'll be turning the last page, as it were. But I have been made aware that it can come back.
It's similar to the flight socks that you wear for long-haul flights.
I used to do a lot of long-haul flights, but never wore any socks.
You got a marking pen? Excellent. Good morning.
How are you? Patel. How are you?
Yeah, we're good, thank you. So, we are obviously going to remove this tumour from the side of your face, and it's going to be quite an extensive resection.
This time, the plan is to remove not just all the cancer, but significant amounts of surrounding tissue too. Richard will cut and then remove the skin and muscle on the temple, cheek, and around the eye where the tumour has invaded, taking good margins in the hope it doesn't return. Then he must drill and remove bone, including a section of the zygoma that forms part of the eye socket, where a tiny mistake could cause blindness. Finally, the surgeons will reconstruct the areas where skin, muscle and bone have been taken away, using a mix of metal scaffolding and a section of skin and fat taken from Paul's thigh.
So I think you're going to lose about half of your eyebrow.
Yes.
And possibly the outsides of your eyelids.
It's a big operation, and the outcome is not guaranteed.
The main risks are we don't get it all out in one go. These things can come back. And obviously we're going to do our best to minimise that risk for you. There is a risk that the tissue that we move from one part of your body to another doesn't like being moved to where it goes to. And in those circumstances, we may need to do something to salvage the situation.
Right.
Have you got any other questions?
Nope, nope. Let's go on with it. It gives people the royal wave as they go past. That's right there, that's right there. I don't think there's much turning back, as they say. That's not really an option. I'm praying that this is the end of the line and it will be sorted.
In Theatre 20, a team of 9 are preparing for Paul's operation. Richard and Animesh will be joined by 2 registrar surgeons, an anaesthesia team, and 3 scrub nurses.
Anticipated time all day?
Yeah, 6 hours.
Most of the day.
Yeah. Anything else from the team?
Yeah, we need a patient.
Yes. Yeah.
Welcome.
It's good to see you and get this out.
Are you still working?
No, I retired about 8 years ago.
8 years ago. Okay. What line of work were you in?
I was Air Force.
Oh, right. What did you fly?
Harrier.
Oh, wow. Gosh. Sharp scratch coming. You must be something special to have flown the Harrier. Seriously. So a couple of nice, slow, deep breaths. We'll see you soon, okay?
As soon as the patient is on the operating table, their life is in your hands.
Cool.
And you need to be able to work efficiently, meticulously, and safely for the benefit of the patient.
Okie dokie. So we're all good, right? We are all good.
First, a plastic yellow cover is placed in Paul's eye to stop it drying out during the operation.
Thank you. Okay, we're starting. Straight down.
As Richard cuts into the cancerous area of skin, he'll need to ensure he cuts wide enough and deep enough to give a margin of healthy tissue around the cancer. This will ensure he clears the tumour completely.
Yeah, I'm always slightly nervous about leaving anything behind, and if you're going to do an operation that's a big operation, there's no point going half-hearted on it. Just do a big operation. Very, very carefully. Just you need to get under the muscle. We want that out. Yeah.
Together with his registrar Bilal, they'll cut up to 2.5 centimetres deep into the facial tissue, with an extra 1 centimetre margin around the cancer.
So this is going to reflect underneath,
yeah,
and then come around on the fossa, yes?
Yeah.
So you need to scoop underneath the... Yeah. It's important to remove the tumour in one piece so that we don't get tumour spillage. What can happen if you're operating and you cut through the tumour is that cells from that tumour can seed into the wound that you leave behind. There's a little hollow under there that's full of muscle. We want that out.
Okay.
Yeah? So the worst thing that can happen in this operation is that we fail to remove all of the cancer. And to me, that is failure.
The only way Richard will know if he's cut big enough is to analyse the tissue when it's removed.
I have a specimen.
Thank you.
Upstairs on the 4th floor is England's largest pathology team, a joint enterprise with Royal Papworth, where 170 people work to deliver cancer results to patients.
This is a specimen where the surgeons removed a breast cancer.
Among the 50 consultant pathologists is Elena Provenzano.
So when I tell people I'm a pathologist, they often assume that I, silent witness type stuff, whereas autopsies is a very, very small part of what we do.
Acrylic paint is used to colour the different edges, so they can orientate the specimen later in the process.
The thing that amazes people the most is what a manual process it is. We need to convert the specimen into very thin, 1-cell thick sections for glass slides. And in order to do that, the tissue needs to be mounted into wax first. that we can cut into wafer-thin sections. In the slicing room, we use a special machine called a microtome.
It's about 5 times sharper than a razor blade.
It allows us to take these very thin sections that are only 3 microns, so 3/100th of a millimetre thick, which we can then pick up on the slide to look at down the microscope.
Once on the slide, they're ready for Eleanor to examine.
This is the part of my job that I find the most exciting and also the most challenging. I've always got in the mind what my diagnosis means for that patient. And it's very personal for me because my own sister had breast cancer.
Eleanor's sister was pregnant when she was given the diagnosis.
They delivered my nephew slightly early so they could start her on chemotherapy. And unfortunately, my younger nephew was only 18 months old when she passed away. Sorry. So it was very painful, but in some ways I find my work even more rewarding now. It's about trying to get better outcomes for people like my sister. This is what the cancer looks like.
Eleanor is looking for a rim of normal tissue around the tumour that's clear of cancer cells.
We've got blue ink here. The blue ink is what I was doing when I was painting the specimen. It's a long way away from the tumour. The tumour's been completely excised. The surgeon will be able to reassure her that all the tumour's been removed and that she doesn't need to have any further surgery. So there's a bit of good news for the patient with this particular tumour.
Next door in Royal Papworth's Theatre 4, Armon is preparing to remove a tumour from the airway of 30-year-old Danny.
Now give me some forceps.
He's taking the most direct route through the chest wall.
And can I have the table up a bit, please?
To make it easier to operate, her lung has been deflated so that air will not move in and out during the surgery.
Right, your lung's down, isn't it?
Yes.
Right, can I have the periosteal elevator?
The tumour, about the size of a ping pong ball, is lodged in Danny's bronchus near the junction of her main airway. To safely extract it, Armon needs to separate away the pulmonary artery, which takes blood from the heart to the lung and sits dangerously close by. Only when he's safely negotiated around this vessel can he isolate the airway tumour and upper lobe of lung and remove them. Finally, the remaining end of the airway needs to be reconnected to the lung.
What's the diathermy on?
Big operations that are quite complex are a mixture of excitement, fear, challenge, a whole gambit of things that goes through your mind.
Their first task is to isolate the tumour-filled airway away from the structures around it. Armon uses an endoscope camera which magnifies by about 20 times to get his first look inside the chest cavity.
Okay, stuck lung.
But he's discovered scar tissue, or adhesions caused by repeated infection, has stuck the bronchus to the blood vessels and tissue around it.
The adhesions tell us that surgery is likely to be very intense with an increased amount of difficulty and risk, because although they're quite tough adhesions, the structures that they are adherent to tend to be very fragile, so we have a risk of bleeding.
Can I have a knife now, please? I can see where the lung is stuck, where I think. Knife? Thank you. I'll just cut the pleura. Hopefully the lung will start to fall away. Yep. Okay, good. Right. When it gets to the nitty-gritty of separating out the important bits, things can be very stuck and it's very easy to go into the wrong bit or for something to rupture.
But it's not the only issue for Armon.
So there is some bleeding from around the origin of the pulmonary artery, which is a very bad place for bleeding. Sucker, please.
There's a tear in the pulmonary artery, the main vessel supplying blood from the heart to Danny's right lung. It carries 3 litres of blood every minute. A rupture here could be fatal.
Now give me the spreader. So what we're doing is we're just pressing on it and getting ourselves even more exposure so that we can deal with it.
The pulmonary artery is probably one of the most fragile vessels in the body. It does not enjoy being handled or manipulated in any way, shape or form and will tear very easily. Even just touching it sometimes with a sucker can cause damage.
There's a bit of blood down there, actually.
Arman must locate the source of the bleed and stop it before it gets worse.
Okay, I want to see what's going on down there.
You've got some... No, it's from the back.
Come away. Come away. We could have terrible bleeding, catastrophic bleeding from the pulmonary artery. Wise words from older surgeons were just pause, regroup, and go back to doing what you know you can do.
Can I compress?
Can you see where it is coming from?
In here somewhere, but I think it's the incrusted.
Everybody is aware that we're in tiger territory, if you like. Something that's potentially dangerous.
Just give me the sucker.
Arman uses a swab and pressure to stop the bleed.
Now hopefully it will allow us to have a look at this now and figure out what we're going to do.
But he still needs to cut away the tumour-filled bronchus from scar tissue around the pulmonary artery without causing any more bleeding.
It's extremely stuck in the bad places. I hope you're not in a rush. It's certainly taking me longer than I mean, it's very stuck proximally. I've done thousands of operations now, and I have to say this is one of the most challenging I've ever had to do because everything is so stuck together, things could so easily go wrong.
If Arman decides that continuing to separate the bronchus from the vessels is too risky, the only way he'll be able to safely remove the tumour is to take drastic action.
Because of how stuck it is. There is a real chance that we might have to do a right pneumonectomy here.
A pneumonectomy means taking out Danny's entire right lung.
I try not to think about failure. I'm having to keep myself steady.
We're both really hoping that it doesn't go that far. If that's what we have to do to keep a patient alive at the end of surgery, then that's what we have to do.
I don't like to think about saying goodbye. I want to be there every moment. Danny and I have had that conversation in the event of worst case scenario. It wasn't easy to have to bring that up. Honestly, I'm petrified.
In Addenbrooke's Theatre 20, Richard and Animesh have started to cut out the cancer that's spread across the side of Paul's face and has started to invade around the eye.
It should start to lift off now, yeah? As you get down to a deep, dark hole, yes?
The only way to cut out the tumour is to remove muscle and nerves that support Paul's eyelid and his blinking function.
You can pull it up. Yeah? Yeah. 2 seconds on that. Rock and roll.
They might have cut away the section of cancerous skin and muscle,
And then the burr, please.
but to make sure they've got all the disease with a good margin, they need to go further.
I'm going to take this off of here.
Yeah.
All the way up to there. All of that up.
The cancerous tissue has been sitting on the delicate zygoma bone, at the side of the eye socket.
Beware, because where I've got my finger now, wafer thin.
So Richard wants to drill it and nearby bone away in case it's been invaded by cancer.
Just be careful. Don't go through the zygoma.
No.
It's not very thick at that point.
Yeah.
It's fragile, just a few millimeters thick and right next to the eye.
So when you're drilling around the eye, there is always the risk of blindness. The drill is spinning at thousands of revolutions a minute. It's a very fast drill. Now that has pros and cons. It means it cuts through bone quite easily, hot knife through butter, but also if it slips, it cuts through anything else quite easily. So you're going to want to go round here and then parallel to me, okay?
Richard is working closely with experienced registrar Bilal.
Need to go through this room a bit more. Stop. Any deeper here, you'll hit something important. Yeah.
Just a millimetre in the wrong direction, and they could penetrate the eyeball, leaving Paul blind.
Careful, careful, careful. Wonderful. You're through there. So you just peel it off, orientate it. Well done.
Thank you.
Very tidy.
Thank you.
They hope that the good margin means they finally removed all the cancer.
Taking the tumour out is not a champagne moment. It's not time to go home and relax. It is a big step in the process, but there's still work to do.
There's a 7.5 by 6.5 centimetre hole in Paul's face that must be reconstructed. And now the bone's been removed, the eye socket needs to be stabilised. To rebuild it, a metal plate will need to be screwed into the orbital bone surrounding the eye. To fill the hole in Paul's face, Animesh will harvest a flap of skin from his thigh. Finding and separating out the flap's artery, vein and small branches from the dense muscle around it. Then, the flap can be placed in the hole, attaching its artery and vein to blood vessels in the neck, so it's alive again. Finally, it can be stitched into place around the temple, cheek and eye.
So we're through the skin, now into the fat.
Animesh begins to cut out the flap from Paul's thigh.
Yep, arrows downwards towards the thing. Yeah, we can do that.
While Richard turns his attention to the weakened eye socket.
Obviously this isn't here now, and so the idea next is to put a little plate here just to reattach that. Otherwise his eye will slowly get more and more droopy with time. Operating on people's faces is something that not all surgeons are comfortable doing, and it is part of the challenge of plastic surgery, is to give as good a result as you can. Clearly this is something that people will be able to see, the scars that I put on their face. And so it does have a personal side to it. We need about that to bridge the gap. One of them. What? One of them.
Richard uses a 3.5 centimetre titanium alloy plate with holes for several screws to bridge the gap left in the zygoma bone.
Wunderbar. Voila.
Finally, as the nerve that aids closing the eye has been removed, Richard needs to try and restore function.
We're going to pop a little gold weight in this lid. Another knife, scalpel, that's the word, scalpel.
Gold is used because it's less likely to irritate. This 1.4 gram weight will use gravity to allow Paul to close his eyelid.
So the gold weight is going to sit inside the eyelid, like that, where it's going to allow the lid to fall. The tricky part is stitching it in. Stitching the gold weight in takes a degree of precision. It's all about control of movements, slow and sure passage of the needle. Lovely. Almost looks like we know what we're doing, isn't it?
Right, I might just open this up a little bit more.
Yes.
To complete Paul's facial reconstruction, Animesh is cutting away a flap of skin and fat 2.5 centimetres deep from Paul's thigh.
This should be the septum.
Flaps for this type of surgery are sometimes taken from the arm, but the thigh provides better tissue and a contour to match the side of the face.
So choosing the thigh for the donor site, I know it's going to be more challenging than certain other donor sites may be. But for me, this is a block of tissue that I know is going to be an excellent fit for the reconstructive challenge that we have.
The thigh is more challenging because the anatomy is very different from person to person.
It's like this is entering the muscle quite high up.
Paul's thigh is especially complex. The vein and artery he needs to bring with the flap are buried in the thigh muscle, making them tough to find and cut free.
Normally this runs in this septum, but it's doing something different today.
Even worse, Animesh must deal with dozens of branch vessels, known as perforators.
What I'm finding is these perforating blood vessels are going through Paul's thigh muscles, and they're very small. So when it's in the muscle, it's a lot more challenging, isn't it? If any of these structures are damaged at any point, that's game over.
He needs to preserve the vessels, or there's a risk blood won't flow through the flap properly, and it will die.
How you getting on?
It's a real struggle today. Everything is intramuscular, including the pedicle. You think I'm joking, but I've not seen one like this before. What time is it? Man, coming up to 2 hours, I don't believe it. Oh dear, oh dear.
If Animesh can't make this flap work, he'll have to find another and start all over again.
You okay there, mate? You okay? We're going to have a flap at the end of this.
You will have a flap, don't worry.
I have a flap.
You will have a flap.
Might not be the one I was expecting.
We're just getting the pulmonary artery free now.
In Royal Papworth's Theatre 4, Armon is behind schedule. He's been having difficulty freeing up Danny's bronchus from the fragile pulmonary artery.
Yeah, we are progressing. It's not like one of those easy-peasy cardiac operations, you know? It's not like, oh, it's all there, let's just chop it out and put something else in.
He's now ready to remove the tumour-filled airway and damaged upper lobe.
Put the diathermy back to 30, please.
The moment just before I remove the tumour with the airway and lung is the most decisive moment of the operation, because at this point I'm going to commit. I have to know exactly where I'm going to put my cuts. The cuts have to be perfectly placed.
Because the tumour is cancerous, Armon must take a margin of healthy tissue around the tumour. But that means once again, he's forced to cut close to the pulmonary artery.
Are you ready? Nice. So we're now dividing the bronchus intermedius.
Stitch coming.
Where that swab is, the pulmonary artery is just around the other side. Right, stitch please.
There's no margin for error. Cut too little, and he risks leaving behind cancerous cells. Cut too much, and he could tear the pulmonary artery again.
Scissors. Can they just shut up? Can you just stop talking, please?
With one end of the airway free, Armon is just one cut away from finally freeing the tumour and upper lobe of lung.
Suck in there. Now I'd like the stitch, please. Suck in there. Just relax. Don't pull anything, okay? Suck in there. Okay, right.
The tumour and upper lobe of lung is out.
Susan, just look at this.
The 7 by 6 centimetre sample will be sent immediately to pathology for testing to see if Armon has removed all the cancer.
Okay, right, take that, send that off, please.
when we get the tumour, airway and upper lobe out. There's no sense of relief because the next really important part of the operation begins, and I have to move forward decisively and swiftly. I have to put these things back together again, and it has to be done smartly.
For Danny's lung to work, Armon will sew the two sections of airway together. A challenge, as one end measures 1.5 centimetres across, while the other is a third smaller.
Let's bring this one together.
If he can't make the joint airtight, Danny's entire lung will be at risk.
That's good. Clip, please.
So you've got to do to this side, this to this side, because you haven't done that yet, yeah?
The hurdles we go through for this surgery are huge. If you're asked to run a marathon and you've never done it before, it would be that sort of thing.
Super gentle. This is really delicate airway.
And that the concentration is the hardest thing because humans don't tend to concentrate for hours on end.
Wait, I'll give it to you. I'll give it to you. Take it. Going well. Take it, gently.
Armon is using his preferred method of sewing from the back of the airway to the front.
Don't do anything. Let me take it. Okay, now we've got a problem.
We've got a hole.
Right, we've got a hole in the PA, so you're going to get blood in the airway. Okay.
As Armon has pulled the two ends of the airway together, the pulmonary artery has torn and started to bleed again.
Right, suck in there.
That feeling of fear, it's the fight or flight. So you just internalise it and work with what's coming.
Stop ventilating for a second. Suck vigorously around the top. Right, just everybody stop for a moment. We have a problem.
What's up?
The problem is a big problem.
If Armon continues to sew the airways together with his current method, it'll keep pulling on the pulmonary artery and make the small tear bigger, risking a torrential bleed.
Give me a 4-row proline first of all. We really have a problem that this could become a pneumonectomy.
The pulmonary artery is just too much in the way, and it's very likely that if I try to do what I'd planned, I'll end up damaging the pulmonary artery or kinking the airway so that air doesn't go in and out of it properly, which would just be a disaster.
Just gently, there's too much tension on it.
You have a new sponge stick?
Just wait. We have a situation where things could just fall apart here.
No surgeon likes to be in that moment.
I thought it was going to be okay, but obviously bringing it all together is quite a lot.
I'm really quite cross with myself. I cannot see where to put the next stitch. I've got no choice. I have to take control of this.
I need to redo this differently. Give me a 4-row proline first of all. And get me a, get me a sponge stick. So I'm going to have to take down the back wall and repair the PA.
To make the joint work and keep Danny's lung, Armon has to take out all the stitches and start again.
When Arman says this won't do, it won't do. And if it's anything less than perfect, then we're bound to redo it. And if that means taking something to bits and redoing it in a different fashion, so be it.
It's not designed to come apart, but today it has to. Yeah, so just take it out, Julie. Gently, 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 everybody.
First, Armon applies pressure and stops the bleeding to the tear in the pulmonary artery. He's now in a position to try to make the joint again.
We really are beyond the point of no return. I've got to make this joint work. Failure is just not an option.
Right, once I've got a couple of these in, I can take that first stay out. Now, let's just see how that's looking. I think it's not really pulled through enough actually on my side, but I don't want it to cheese wire. So hold on, let me just very gently draw it towards me. Come on. Gotcha.
Armon has just a few more stitches to complete the join. He wants anaesthetist Guillermo Martinez to use a camera down Danny's airway to see if the join is coming together.
Okay, going to the right.
Good. Can you see my stitch?
Yes, I can see your stitch. The needle is just in front of the camera.
So 3 or 4 more throws and we'll be there. So I just want you to check that we haven't got any...
I can see the lower low.
Good. I just want you to check that we've got no... that I'm not making any mistakes at this stage.
The join needs to be completely airtight.
That's better. That's more like it. Right, now hopefully... just 2 more. Just don't pull it. Yeah, but no, actually that was good. Just hold it like that, just like that.
The last stitches are in. It's time to check the airway is working by trying to inflate Danny's lung with air.
Okay, lung coming up.
Oh, lovely. Just let the machine do it. It's coming up really nicely. Yeah, it's really shooting up, look.
When the lung suddenly moves and becomes pink and you can see the air going back into it is a lovely moment for a thoracic surgeon.
Okay, yeah, good, lovely.
That's nice.
It's taken 5 hours. Armon has safely cut out the tumour and reconnected what's left of Danny's right lung. But has the pathologist found traces of cancer in the margins of what was removed?
Yeah, thank you.
So proximal and distal resection margins, they both appear clear of tumour.
Thank you. Okay, thank you. Guys, the margins are all clear.
Bravo!
Okay. Thank you, Stephen. So, I'm really sorry to keep you late, but that's so wonderful. Thank you. Okay, guys, it's good news.
Danny can hope for a cancer-free future, but it'll be a few weeks before the airway is healed completely.
You know what? I actually found that more difficult than usual.
Yeah.
Yeah, I have to say.
She was difficult, but she, you know, this will be good for her at the end of the day, won't it? She'll go home to her family happy, and she's still got most of her lung there.
Man, oh man. Man, oh man.
At Addenbrooke's, in Theatre 20, Animesh is struggling to cut a flap of skin and muscle from Paul's thigh.
Still don't see how this deeper one joins up.
He needs it to reconstruct Paul's face, where the cancer has been removed.
Looks like you got the easy bit, Richard.
But the main blood vessels and small branches that Animesh needs for the flap are buried deep in Paul's muscle tissue and are proving difficult to isolate.
I'm hoping that everything is free now. Oh, he says, finding another bit that's not free. Okay.
Whenever I'm faced with a challenging situation, I block out everything that's around me. It's me against the dissection, and everything else fades away.
Right, that's that free.
After 3.5 hours of painstaking work, Animesh is finally there.
You can relax. We've got a flap.
It's taken twice as long as normal, but he's separated out the vein and artery attached to the flap.
Oh man, I've not done one that complicated since I was a registrar, I don't think.
I think to congratulate myself at this point would be premature. We're only halfway through the operation.
So this is our flap. Going to go on the head there.
Ah, very good. Perfect match.
almost like it was made to measure. This vessel is going to come under the skin and out just there.
These 10-centimetre long vessels on the flap need to connect to the blood vessels in Paul's neck. Without a blood supply, the flap will die.
The reconstruction involves connecting the tissue to the head using an artery and a vein, and it's no different to a radiator. There's a pipe that goes in and a pipe that comes out, and they both have to work. If either of those blood vessels doesn't flow, the tissue will die, and we'll be back with a big hole in his head.
So that's the flap in situ. All we have to do now is join up the blood vessels.
Yeah. Make it alive again.
Make it live.
The two surgeons will now swap places. Richard will close up the hole in Paul's thigh and use a skin graft to repair it. A slight indent will remain, but it won't affect the use of the leg. Meanwhile, Animesh has the delicate job of connecting the blood vessels from the flap to those in Paul's neck.
Right, let's get the microscope in, team.
The microscope will magnify the vessels up to 15 times.
When we're suturing under a microscope, it is very small, delicate movements that we have to perform to get those things done.
Okay, let's have a 3.0 venous coupler, please, to join the two vessels together.
He starts with the vein, using a coupler device to connect the two ends together with a plastic ring.
So if you can push on those, although we put the vessel ends over the prongs, so that's that ready. And we just need to do the same over here. Okay, ready to close it?
Yeah.
Okay. A clamp applicator to me, please. Thank you. So just try and be mindful that you want to kind of stay down. Right, let me know when you're engaging.
Now.
Okay. Just give that a squeeze just to help it. Okay. Let's just take that clamp off. Okay, so the vein is on. Vein on, team.
Vein on.
Because the arteries walls are too thick to fold onto the coupler, he needs to sew these by hand. But they're just 3 millimeters wide, and the thread is 0.04 millimeters thick.
Right, that clamp off, and let's see if our join is working. The flap's on.
With the veins and arteries both joined, they need to test whether blood is flowing in and out of the flap.
So we are inspecting the flap now. Yeah, still happy with the colour.
If a flush of blood returns to the flap once the finger is released, it shows that it's working.
Looks okay?
Yeah, not bad.
It's not cool?
The flap on Paul's face is alive.
Been third time for this problem.
Yeah. Oh dear.
And it's always difficult knowing where the cancer starts and stops.
Yep.
Because Paul's cancer specimen includes bone, it needs to be softened before pathology can slice it onto slides. So the results will take several weeks to come back.
So at the end of Paul's operation, there's a number of things that we don't know whether we've got the whole tumour out. I don't know whether I've made him blind during the operation until he wakes up.
Not out of the woods yet.
There, Paul, how are you doing? You all right? It's all finished? You're just waking up, okay? How are you feeling?
Whenever I do a case such as this, there is still something in the back of my mind which says, is this patient still okay?
Come through.
Hello, yes.
Just over 2 weeks after his surgery, Paul has returned for a checkup.
How are things?
It's getting better day by day.
The swelling certainly is reducing. Yeah, very good. Do you mind if I have a closer look?
Certainly not.
There's no way of getting a perfect result, but we have got an excellent result. given the limitations of harvesting tissue from another body site.
The flap is still swollen, but will improve.
Brilliant. Yeah, that is all doing very nicely, and your eye looks very good as well.
I think that swelling will get better and better with time. Happy with that?
And you're able to close your eye? Excellent.
Animesh also wants to check where the flap was cut from the thigh.
Where we take this type of skin graft from heals on its own, and that is all settling in very nicely.
Paul's pathology results are back.
As it sits, he's tumour-free, so we would not expect this to come back. I'm hopeful that outside of the cosmetics, he's got a perfectly good future ahead of him.
It's gone as per plan. The rate of improvement has been very good. I'm very confident that it will continue to go that way.
This is the best result we could have hoped for.
I'm going to continue the recovery, and eventually we'll be able to start travelling again.
Danny was allowed home 4 days after the operation to remove the tumour from her airway. Today, she's back for her final post-op check. Armon puts a bronchoscope camera down her airway to examine his stitches.
And it's going to freeze a big lump.
And to see how the new airway joint is performing.
Hi, Danny.
Hiya.
Can I come in?
Yes, of course.
Yeah, okay. I'm really pleased with the joint. Even if I say so myself, I haven't seen one quite as nice as that. The margins are all clear. We've got a good extent from the tumour. So the chance of it coming back is extremely low. And
worth it then?
Yeah, it was worth it, yeah. All right, okay, I'll see you later.
See you later.
Okay, all right then. Take care.
Bye.
Take care.
Someone said to me, what are you doing now you've been given a second chance? And that almost was like, wow, I didn't see it as a second chance. So I think live every day as it comes now and to the fullest.
I thank my lucky stars that she's still here. She's lucky to still have her life. She's lucky to still have part of her lung. We can go and lead a better future. That's what it means. We have a future together.
Sophie.
Now she's going to have a normal life. She's lost no working lung, the infection has gone, and the healing looks great, and all the tumour is out. I'm really pleased, yeah. Honestly, it looks about the best anastomosis result that I've achieved. So I must be getting better with age.
Next time.
It's an operation that changes the patient's life forever.
Life-saving surgery.
But you might not even wake up.
So extreme, it's pushing the boundaries of science.
No response?
And again.
No.
We are right at the limit of what a human body can tolerate.
How's that?
It's not great, is the honest answer.
We're right on a really perilous bit.